Vasospasm, and today we have with us Professor Bibu Kalyani Das. She is a senior consultant and head of the Department of Neuroanesthesia at Institute of Neurosciences, Kolkata, and she has contributed immensely to the development of neuroanesthesia and neurocritical care in India. She is one of the founding members of ISNAC. And we have today with us our recent DNB pass out, Dr. Anil Piruru. He will be presenting the class on the management and the pathogenesis of cerebral vasospasm. Dr. Anil, he is now working as a consultant at Amara Hospital, Tirupati. Over to you, ma'am.
Yes, thank you very much, Julfikar. I'm so proud and I'm so happy that you are conducting these classes, which is very important for our students and also for us also. We also educate ourselves. So thank you very much once again. And I welcome all the participants today, this evening. So we have a very important subject to discuss, that is aneurysmal, no, it is cerebral vasospasm. And this will be dealt with by one of our junior, very bright colleague, Dr. Anil Babu, and he is now consultant that has been introduced by Dr. Julfikar, and he has already discussed with me, and I am sure that you all will be benefited by this, and I want all of you to participate in the discussion. So make this very challenging and very encouraging. So thank you very much. Without wasting time, I'll request Dr. Anil to go for when he's going to discuss about the pathogenesis, about the causes and what is vasospasm, how you detect, how you monitor, and how you manage, and how you prevent. So all these things will be dealt with by Dr. Anil Babu. Anil?
Yeah, ma'am. Good evening, ma'am.
Please.
Yeah, ma'am. Yeah, thank you. Good evening, all. So before starting my presentation, I would like to wholeheartedly, I'm thankful to Julfikar sir for giving this opportunity to present a topic. So all these opportunities are making us to improve ourselves in academics, and I'm wholeheartedly thanking you, ma'am, for being my this session moderator. So I'll start with the presentation. So cerebral vasospasm. So what is a cerebral vasospasm? Cerebral vasospasm is a reversible narrowing of the cerebral blood vessels, usually seen post aneurysmal rupture. And it's not the only condition where we see cerebral vasospasm. There are few other conditions where a cerebral vasospasm can be seen. Most importantly, other than aneurysmal subarachnoid hemorrhage, it is seen in traumatic brain injury and in reversible cerebral vasoconstriction syndrome. So this reversible cerebral vasoconstriction syndrome usually is seen in postpartum patients where they have an unusually high blood pressures along with MRI findings. Clinically, they have a presentation of a thunderclap headache, similar to the SAH presentation. Yeah, and then even we see cerebral vasospasm post brain tumor resection, and in non-aneurysmal SAH, where we see an massive blood hemorrhage in the subarachnoid space. Even with non-aneurysmal SAH, cerebral vasospasm can be seen. So what we see in an aneurysmal rupture of aneurysmal rupture post SAH patient, usually if you see any delayed deterioration of these patients along with the cerebral vasospasm, we have to look for the other causes before coming to a conclusion that patient can have a vasospasm. These are like initially we have to do a CT scan after suspecting the patient deterioration and the related complications. So by seeing a CT scan, we can see the hydrocephalus or we can see any ongoing bleed or infarct or any rebleeding. Along with that, we have to rule out the infections, neuroinfections like ventriculitis, meningitis, sepsis, and even metabolic disturbances. We have to rule out hyponatremia, and we have to rule out hypoxemia, and even there are few other causes which can have a detrimental outcome in subarachnoid hemorrhage, like cortical spreading depression or early brain injury. All these can lead to delayed cerebral ischemia. So, cerebral vasospasm is not the only cause for delayed cerebral ischemia. There are few other causes, but the major important risk factor for delayed cerebral ischemia is cerebral vasospasm. Today, we are limiting our discussion only to the cerebral vasospasm, and all the other complications we can have one more session. So these are the articles I have prepared, and I have prepared the PPT from these articles. So usually, along with the cerebral vasospasm, delayed cerebral ischemia, these two are sometimes a patient with delayed neurological deficits can be called as a delayed cerebral ischemia. These are the poor outcome markers for an SAH. Usually, 50 to 90% of the patients of SAH patient can have angiographic vasospasm without any clinical presentation. So among these 80% of the patients, the patient can be symptomatic in only up to 30% of the patients. And the delayed cerebral ischemia can be related to the cerebral vasospasm, or it cannot be related to the cerebral vasospasm, where the other factors could be a reason for the delayed cerebral ischemia, along with the vasospasm. So usually we see cerebral vasospasm on day 3 of the ictal event, and it can peak the peak stage for cerebral vasospasm is around the end of the first week, and it can persist up to 21 days. So usually the angiographic vasospasm is when we do a vascular imaging, usually we see narrowing of the cerebral blood vessels, and patient can have symptoms or cannot have symptoms. Usually the angiographic vasospasm incidence is around 70% of the SAH patients. And then clinical vasospasm, where patient can have ongoing cerebral ischemia due to the narrowing of the cerebral vasculature. Basically, this cerebral vasospasm is a diagnosis of exclusion. As I said before, we have to rule out all the possible other alternative possibilities like hydrocephalus, seizures, rebleeding, hypoxia, and other metabolic disturbances before coming to a conclusion of cerebral vasospasm. Usually, how the patient will present. Patient can be awake initially, or patient can be already with a low GCS initially. So when you see a new neurological deficit in these patients, which was not present during the admission time, then we can suspect a cerebral vasospasm, ongoing cerebral vasospasm. So the incidence, usually the people around 40 to 60 years are more vulnerable, but and even a child or even the elder people can have an aneurysmal SAH. Usually 12% of the patients, they usually die before they get the medical attention. And then 40% of the hospitalized patients, they can, chances of mortality is very high in 40% of the patients within a month. And even the survivors who have got the timely treatment, they can suffer a major neurological deficits. So usually this SA subarachnoid hemorrhage is a medical neurological emergency. The highest risk factor for the mortality is not the cerebral vasospasm, but the early rebleeding. That's why usually we have to plan the coiling or clipping after an SAH is seen, initially to avoid the early complications like early rebleeding to reduce the patient mortality. And usually we can use the CT brain or cerebral angiogram, or by doing a lumbar puncture, we can come to this diagnosis. Usually these patients has to be planned for clipping or coiling after stabilizing the patient to avoid the initial complication like debleeding. Even the cerebral vasospasm is more common after the clipping, not the coiling, as the studies are saying like that. Yeah. So I'm limiting my discussion only to the Fisher and modified Fisher grading scale, as this is a CT brain based grading, where the patient chances of getting a vasospasm is based on the initial thickness of the subarachnoid hemorrhage and with or without the presence of IVH. So here you can see in for Fisher scale there are 4 grades. For 1 and 2, it is thin SAH, and for 3 and 4, it is thick SAH. For 4, with ICH or IVH. And you can see the vasospasm incidence is going high. For 4th grade, it is 31 degrees, for 31%. And you can observe here for 3rd grade, the vasospasm incidence risk is around 37%, which is higher than the 4th grade. So that's why nowadays people are considering modified Fisher scale, which has 5 grades: 0, 1, 2, 3, and 4. This is more easy to remember. 0 is no SAH, no IVH. Grade 1 is thin SAH without IVH. Grade 2 is thin SAH with IVH. 3 and 4 without IVH, with IVH, but both are thick SAH. So for this, the incidence of vasospasm is increasing based on the grading. So here is the CT based grading. You can see the modified Fisher. Grade 1 is no SAH, no IVH. Grade 2 is minimal subarachnoid hemorrhage with IVH. Grade 3 is thick SAH without IVH, and grade 4 is thick SAH with IVH. Based on the grading, we can anticipate the cerebral vasospasm in these patients. So what are the risk factors for vasospasm? So the initial presentation of the patient, and the initial, when patient has a history of LOC at the time of aneurysmal rupture, or a thick subarachnoid clot in the CT along with IVH, or delay on repeated CT brain. If you are seeing the same persistence of the subarachnoid clot, usually it indicates a delayed clot clearance. These patients can have a more chances of having cerebral vasospasm. And then initial GCS, and initially if a patient is on mechanical ventilatory need, these patients can have more chances of vasospasm. And even along with this, modifiable risk factors like cigarette smoking, cocaine use, and non-modifiable risk factors like existing hypertension, diabetes. These are the risk factors for vasospasm incidence. Even the incidence of vasospasm is based on the location of the aneurysm. So some aneurysms like pre-pontine SAH or pre-truncal SAH has a lower chances of vasospasm because of minimal escape of the blood into the subarachnoid space. And then DACA aneurysms have higher chances of vasospasm. So coming to the pathogenesis, there are many theories explaining the cerebral vasospasm. The mainly what the literature is saying is this arachnoid, the oxygenated blood, hemoglobin, because of its auto-oxidation, and it irritates the subarachnoid space, thereby triggering the inflammatory reactions, and then calcium-dependent and calcium-independent vasoconstriction mechanisms. Along with this, due to the rupture of the endothelium because of the aneurysmal rupture, the release of endothelin, which is a trigger for the vasospasm. Along with this, there is a concept called biphasic vasoconstriction, which we see in the cerebral vasospasm. Usually, the first phase of cerebral vasospasm is reversible and is mostly dependent on calcium metabolism, because the calcium which is released into the subarachnoid space due to the irritation of the oxygenated hemoglobin into the surrounding tissues, the calcium can trigger the myosin light chain kinase, thereby triggering the actin myosin cross linkage and causing the vasoconstriction. This calcium dependent vasoconstriction is can be reversed by using the CCBs like calcium channel blockers. But the second phase of vasoconstriction usually is independent of the calcium. Those are mainly triggered by the inflammatory markers. The inflammatory markers usually the same stimulus like oxygenated hemoglobin, which further degrading into the methemoglobin, bilirubin. All these irritants trigger an inflammatory cascade by releasing the complements, cytokines, and then intercellular adhesion molecules. All these increases the vasoconstrictive capacity of these patients, which are independent of calcium. So even these patients, even the calcium channel blockers cannot be work as effective as the initial phase of vasoconstriction. So these patients can have irreversible cerebral vasoconstriction. Further leads to the delayed cerebral ischemia. Along with this, cortical spreading ischemia. So cortical spreading ischemia, actually cortical spreading depolarization with any trigger like mechanical stimulation or electrical stimulation, which triggers an electrophysiological neuronal potential, which increases the cerebral blood flow because of increasing cerebral metabolic rate. Mainly, these are mediated by the release of excitotoxic mediators like glutamate, calcium, and then microcirculation thrombosis. Microcirculation thrombosis, all the small blood clots which were seen in the initial aneurysmal rupture followed by the clotting, this thrombosis and all interrupts the glycocalyx. Glycocalyx is usually seen in the endothelium of the cerebral blood, any blood vessel. So these usually they prevent the platelet aggregation and all. So once the endothelium is ruptured and these glycocalyx is exposed to the platelets or activating complements and complement mediated factors and all, thereby triggering the microcirculation thrombosis. Along with this, free radicals, the auto degradation of the oxyhemoglobin releases the oxygen free radicals, and these oxygen free radicals, they increases the lipid peroxidation. So that's why there are some trials which are statins that has been tried to reduce this lipid peroxidation, thereby reducing the cerebral vasospasm. And as I said before, these are the many theories for the cerebral vasospasm, like calcium dependent vasospasm, calcium independent vasoconstriction, which is the second phase of vasoconstriction, where there is a low response to the calcium channel blockers, and then free radical reactions due to the auto oxidation of the oxyhemoglobin. Mainly the vasospasm, they presents in the patient due to the imbalance of vasoconstrictor and vasodilator substances and endothelium derived substances and arachnoid metabolites, along with this inflammatory processes. So I'll just explain about the endothelin. So usually endothelin, they get exposed to the bloodstream once the endothelium is broken. So this endothelin, there are three isoforms of endothelin mainly. In the brain, these are ET1 and then ET3. ET2 is not present in the brain, and these have two types of receptors, ETA and ETB. So if this ET1 is the major endothelin that presents in the brain. That's why the clazosentan what we use is an ET1 receptor antagonist that has been tried in our trials for counteracting the vasospasm. So this ET1, it has two receptors, ETA, ETB. Binding to the ETA receptor usually causes vasoconstriction, whereas binding to the ETB it can be either. It can be relaxation or constriction. So endothelin-induced vasospasm, usually it can be reversed by the calcium channel blockers. And there are studies where intraarterial nicardipine has been tried and has showed superior results compared to the verapamil in endothelin-induced vasospasm. And then clinical trials like clazosentan, it has showed a decrease in the incidence of vasospasm. Here there is an interesting point. Nimodipine, nimodipine usually it's a class 1 recommendation with a level of evidence A by the ASA guidelines. Usually we have to give nimodipine from the day 3, 60 mg 6 times a day for 21 days. And if patient is hemodynamically unstable, or else if patient pressures are in borderline, then it can be given as 30 mg every second hourly. Usually we give nimodipine to reduce the complications related to the cerebral vasospasm. So nimodipine usually it cannot reduce the vasospasm, but it reduces the delayed cerebral ischemia. Whereas the clazosentan, uh, it cannot reduce the delayed cerebral ischemia, but it can reduce the vasospasm. So this has to be remembered. And then usually clazosentan, it has a side effect like pulmonary complications. And then arachidonic acid metabolites. So usually there are LOX pathway, COX pathway, where there is a release of prostaglandins. Other than PGI2, all the remaining prostaglandins, they are vasoconstrictory in nature. So because of this imbalance, patient can have a cerebral vasospasm. And then inflammation, as I said before, it is mainly a non-specific inflammation, elevation in selectins, in ICAM, VCAM, integrins, all these leukocytes has been noted in the patients who has a presentation of cerebral vasospasm. And then complement depletion has been shown to attenuate the experimental vasospasm. Theories already I have mentioned about all this. Inflammatory mediated vascular remodeling. Usually this inflammatory mediated vasospasm is independent of calcium, where we see the structural damage to the cerebral blood vessels. That's why we are calling it as an irreversible vasospasm. And then other than cerebral vasospasm, there is another reason for delayed cerebral ischemia. That's called early brain injury. So early brain injury is that at the time when the aneurysm has got ruptured. So during that time, a transient rise in ICP has been seen. Due to the rise in ICP, patient can have a global hypoperfusion at that time, which can trigger a numerous inflammatory cascades, cortical spreading depression, cortical spreading ischemia. Usually cortical spreading depression is like protective by as it increases the cerebral metabolic rate, thereby demanding the more cerebral blood flow, it is actually increasing the cerebral blood flow. But in global hypoperfused brain, where there is an early brain injury, in these patients, there is, if you see a rise in cerebral metabolic rate, demanding the more cerebral blood flow, when there is already in global hypoperfusion, there can be a chances of spreading ischemia. That's what happening in cerebral vasospasm. And then capillary thrombosis, blood-brain barrier disruption, ongoing cerebral edema, neuronal apoptosis, or all of these are the things that were seen in the early brain injury that can be a strong reason for the delayed cerebral ischemia. Diagnosis. So before going to the vascular imaging or the other tests like TCD, NIRS, microdialysis, the first diagnostic thing, what diagnosis for cerebral vasospasm is, we have to do a daily regular clinical examination of the patients, and we have to look for any drop in GCS or any new neurological deficits or any new pronator drift or any new weakness. So usually this vasospasm is related to the territory of the aneurysm. If you are suspecting, if patient has an MCA territory aneurysm, and if you are seeing monoparesis or hemiparesis, and if the dominant vessel is involved, then patient can be aphasic. And if it is an ACA territory, usually patient can have leg weakness, sometimes bilateral, along with that confusion, drowsiness can be seen. And if it is a vertebrobasilar aneurysm, patient can have a drop in GCS followed by any pattern of weakness. So as I said before, clinical examination is important, but clinical examination can be done in awake patients only. But the patients who are uptended or already drowsy or patients who are in mechanical ventilation, clinical examination is not a big, it doesn't have a major role in identification in suspecting cerebral vasospasm. So DSA digital subtraction angiography is the gold standard. But the thing is, it's an invasive procedure. The chances of procedure-related risk like dissection, hemorrhagic stroke, or ischemic stroke, these are the 2 to 3% of the patients can have all these procedure-related risks. And there are other alternative diagnostic tests: CT angiography, CT perfusion, transcranial Doppler, MRI, diffusion weighted MRI, and then radionuclide imaging, SPECT scan, PET scan, electroencephalography, NIRS, cerebral microdialysis, PBT-O2, SJB-O2. All these are helpful in identifying the ongoing cerebral ischemia or cerebral vasospasm. So on coming to the diagnosis, first we have to start with the clinical examination and then ruling out all the other possible causes for a delayed deterioration. And then ideally, if we have a TCD facility, we have to do the TCD from day one so that we can follow the trends, and any change in this trend can be a suspect raiser for us. And then for pathological reduction in cerebral blood flow, usually we consider perfusion CT scan. Perfusion CT scan is an alternative to DSA, where it is equally effective. And then SPECT xenon enhanced CT thermal diffusion flowmetry can be used. Thermal diffusion flowmetry is a bedside test where we can see continuously the ongoing of cerebral ischemia. Coming to the for detection of cerebral ischemia, diffusion weighted MRI, NIRS, microdialysis, cerebral oximetry, SJVO2 can be used. And along with this, vascular imaging like catheter-based angiography or CT angiography can be helpful in identifying the cerebral vasospasm. Coming to the TCD, TCD basically we use a 2.2 megahertz probe. Usually we keep in transtemporal window. And it is a non-invasive test, bedside test. It can be repeated as many as we can. And serially, we can follow the patient from day one of admission. But the problem with TCDs, the values are mainly depends on the angle of the insunation. Whereas TCCD, it can't be done here because of the window. But TCCD values are independent of the angle of insunation. So this TCD values usually they have a high specificity for MCA territory cerebral blood flow velocities. So this is the grading of grading based on the mean flow velocities. If it is above 120 up to 150, then we can call it as mild vasospasm, where we can suspect a narrowing of cerebral blood vessel up to 25%. And if it is a moderate, then the cerebral blood flow velocities are up to 199. And if we are seeing more than 200, then it's a severe vasospasm. There is so many ratios for identifying the cerebral vasospasm. One amongst them is Lindegaard's ratio. Lindegaard's ratio is cerebral blood flow velocity in MCA by ICA. If it is above 6, it is severe vasospasm. And if it is 3 to 6, it is mild or moderate. If it is less than 3, it can be a hyperemia. Usually, Lindegaard's ratio is to distinguish between hyperemia and vasospasm. For posterior circulatory aneurysms, there is a Spheri ratio where we get these values by cerebral blood flow velocities by basilar artery divided by cerebral blood flow velocities in extracranial vertebral artery. If it is above 70, it is mild. If it is above 85, then it is moderate. And even Spheri ratio, the grading is there. Above 3, it is severe vasospasm. So this is a moderate vasospasm where we can see cerebral blood flow velocities of above 160. So as I said before, for mild vasospasm, approximately the vascular stenosis is less than 25%. For moderate, it is up to 50%. For severe vasospasm, it is above 50%. So there are other ratios like Jacobson spasm index and vasospasm probability index. In vasospasm probability index, there is they have used even the risk factors as a base to grade the vasospasm along with the TCD findings. And then digital subtraction angiography, as I said before, it is an invasive gold standard test for identifying the cerebral vasospasm. At the same time, we can do the endovascular interventions with this DSA. Usually, it has a recording of pre-contrast image, what we call as a mask, and then there are subsequent images that were taken, and after removing the mask, we can see the narrowing of the cerebral blood vessels. There is a grading of vasospasm even for this digital subtraction angiography, similar to the TCD grading. Severe vasospasm vessel calibration reduction is more than 50%. For moderate, it is 25 to 50%. For mild, it is less than 25%. Usually, similarly to the TCD, the proximal narrowing is more beneficial with the DSA. So, along with this, even an intra-arterial delivery of vasodilator can be tried through the DSA. Vascular imaging, the most practical method is DSA. Even a CT angiography, although it is inferior to the DSA, it is the initial screening test. Catheter-based angiography, it is best in the patients in whom prophylactic balloon angioplasty is being considered. So these are the DSA pre-procedure and then post-DSA. So procedure-related risk factors, as I said before, 2% of patients can have a stroke. It can be hemorrhagic or it can be ischemic, or else there can be a possibility of vessel dissection. Usually this DSA, it utilizes the iodinated contrast. So it has to be used judiciously. CT angiography, usually it requires less contrast medium and it is very fast, reliable and relatively inexpensive compared to the DSA. And it can differentiate the mild, moderate and severe vasospasm. Even it has high accuracy in the proximal vasospasm, similar to the DSA. But limitations are iodinated allergies. And there is an important point to remember here. Usually the CT angiography, which is done after clipping or coiling, in those patients, it gives a suboptimal visualization of the distal vasculature. So we can underestimate the diameter of the distal cerebral vasculature in those patients. And then MRA. MRA, usually it is the radiographically, we can see the narrowing, and then even the physiological measurements related to the vasospasm can be known. Time of flight MRI is inferior to DSA, but it is non-invasive. It neither requires a radiation contrast, and it has a relatively high spatial resolution. So even it can differentiate the vasospasm from the other causes of neurological decline. So positron emission tomography, usually 15O PET is considered. It is gold standard as it provides a cerebral blood flow, cerebral metabolic rate of oxygen, cerebral blood volume, oxygen extraction ratio. There are set of values for these variables. And based on this, we can know whether the patient is having irreversible ischemia, reversible ischemia. Usually the important things are threshold CBF values. For reversible ischemia, it is usually 12 to 20 ml per 100 gram per minute. For irreversible ischemia, it is less than 12 ml per 100 gram per minute. Usually in cerebral vasospasm, there is a decreased cerebral blood flow, decreased cerebral metabolic rate, and cerebral blood volume. And then SPECT. Usually this regional hypoperfusion secondary to the cerebral vasospasm can be seen in this SPECT. And regional cerebral blood flow is assessed by flow-dependent uptake of a radioactive tracer. Usually in these patients, it can reliably detect early changes in the relative tissue perfusion. And then xenon clearance technique, and then xenon enhanced technique, where similar to the other imaging, we can differentiate a reversible ischemia to the irreversible ischemia. And then coming to the NRS, usually we place a adhesive pad over the frontal area on both the sides, and based on the values, we can know whether any based on that number drop. Basically, we see the trends. If there is a number drop of above 13, I guess, then we can know that any ongoing cerebral ischemia is happening. And then microdialysis monitoring, it is a continuous bedside measurement. And usually we see glutamate, glycerol, glucose, lactate, and pyruvate. So these can be seen. And most reliable prediction of ischemia, usually we consider it as glutamate and lactate, because they are the glutamate is an excitotoxic one. And then lactate usually we see when there is an anaerobic metabolism. So usually a raise in glutamate value and lactate value is seen 24 hours before patient presentation. So within this period, we can plan induced hypertension, or if it is resistant to induced hypertension, then we can plan prophylactic balloon angioplasty. So microdialysis monitoring is helpful to identify the cerebral vasospasm before the clinical presentation. Even with glycerol, usually the glycerol values, it peaks 12 hours before the clinical presentation. And then elevation in lactate, it indicates a hypermetabolic state. So presence of a lactate, it doesn't mean that patient is having ongoing ischemia. Prevention of vasospasm. So how to prevent the vasospasm? So usually general measures along with general measures like maintaining euvolemia, and then starting a nimodipine from day 3 to day 21, and avoiding hypoxia, avoiding metabolic abnormalities, and then preventing anemia, and maintaining HB above 9 gram per deciliter. Along with this, accepting a borderline elevation in pressures, and then optimizing the ventilation and oxygenation. Preventing the ICP raise. If patient has an EVD, we can drain the CSF based on the ICP. Nimodipine, and then augmenting the subarachnoid clearance by lumbar drainage of the CSF. And even this one is important. Lamina terminalis fenestration. So when a surgeon is planning coiling or clipping for an SAH patient, during the coiling, during the clipping, not coiling, during the clipping, surgeon can fenestrate the lamina terminalis to enhance the CSF flow, so thereby increasing the clot clearance. So these patients can have a less incidence of vasospasm. So literature is strongly supporting that. So general measures, usually we prevent hypovolemia. Usually SAH is a acute volume contractive state. So patient has to be maintained euvolemic, preferably to prevent the hypovolemia. And then in maintaining the pressures, even albumin can be tried. There is a trial called ALISA, ALISAH. So even it is showing a beneficial effect in augmenting the blood pressures, so thereby improving the overall outcome. And then these patients can have hyponatremia. So hyponatremia usually is detrimental because it increases ICP also. So usually for all raised ICP patients, we target a hyperosmotic state. Like we target a serum sodium of above 150, 150 to 155. So in the same patients, if we are seeing hyponatremia, then these patients can have a grave prognosis. So identifying the hyponatremia, and it can be a CSW or else it can be a CR. So even for CR, like SIADH, for SIADH, the treatment is fluid restriction. But in SAH patients, the fluid restriction can't be tried because already these patients are hypovolemic, and we have to target euvolemia. So the sodium correction can be done with the 3% saline, preferably. Whereas coming to the cerebral salt wasting syndrome, usually we treat cerebral salt wasting syndrome with deliberate fluids. So that can be tried in the hyponatremia with CSW in SAH patients. So if the patient is on EVD, and if we have a chance to measure the CPP, targeting CPP 70 to 80 in poorer graded patients can have a better outcome. And preventing the fever, and early feeds has to be initiated, and a good nutrition has to be ensured to these patients. Nimodipine, as I said before, it is a class 1 level of evidence A recommendation in all SAH patients for 21 days. Usually it is a calcium channel blocker, and it has many neuroprotective properties. Even it has an antiplatelet aggregative properties. So it is very helpful in these patients. So, and then investigational preventive preventive interventions for the vasospasm. Yeah. So prophylactic balloon angioplasty. Can we do prophylactic balloon angioplasty for all the patients? The answer is no. So initially, for a patients for whom we are suspecting cerebral vasospasm, a complete detailed evaluation of the cerebral vasospasm has to be done. And if we are coming to a conclusion that patient is having cerebral vasospasm, immediate BP augmentation, BP augmentation has to be tried. And then BP augmentation, systolic blood pressure can be increased up to 200 to 220, or else MAP can be increased up to 140. So the literature is mentioning that MAP up to 140 can be tried to maintain the induced hypertension. Some patients who are not responding to the induced hypertension, so these patients can be selected for the prophylactic balloon angioplasty. For better results after failure of induced hypertension, prophylactic balloon angioplasty can be done within 2 hours. Clot clearance. So by if we are trying a thing which can increase the clot clearance, so definitely it will be helpful in reducing the cerebral vasospasm. So urokinase and recombinant tissue plasminogen activators, there are trials which are stating that intracisternal thrombolysis can be helpful in reducing the vasospasm, but there is no change in the final outcome of the patients. So intraventricular fibrinolysis. So lumboventricular lavage has been reported to beneficial in some single-center studies, and even fenestration of lamina terminalis, as I said before, at the time of aneurysmal clipping, it reduces the incidence of not just hydrocephalus, but it reduces the incidence of vasospasm from 55% to 30 patients with thick SAH clot. Intrathecal vasodilators. So prolonged release nicardipine implants placed in the subarachnoid space has been tried, and there are some ongoing trials. And then prolonged release nicardipine implants, they are stating like it reduces the incidence of vasospasm. Intrathecal vasodilators. This is another study, nimodipine microparticles to enhance recovery while reducing toxicity after SAH. So this is a pilot study which is on the way. Magnesium. So magnesium, there are IMASH 1 and 2 trials. Magnesium has a vasodilatory property. So usually we use magnesium sulfate. if we are seeing any hypomagnesemia, it has to be corrected. So this is what mentioned in the literature. So by giving an extra magnesium, patient will be drowsy, and we don't know the drowsiness, whether it is related to the magnesium or else it is due to the ongoing cerebral vasospasm. And then other problem is, if you are giving extra doses of magnesium sulfate, the serum levels of magnesium has to be monitored. So usually the literature says intravenous magnesium 12 millimole, 20 millimole administered in 20 minutes, followed by a continuous infusion of 80 millimole per day for 14 days. It did not increase any change in the outcome. That is what they have mentioned. And then STAS trial, even this is based on this, it is not recommended to give statins for all the patients for whom we are suspecting cerebral vasospasm, because there is no change in the outcome. And then endothelin receptor antagonist, clazosentan. There are 3 trials, CONSCIOUS 1, 2, and 3. CONSCIOUS 3 is abandoned after getting the results from CONSCIOUS 2. So CONSCIOUS 1, there was no clear effect on overall outcome, even though it reduces the cerebral vasospasm. So here they have compared 1 mg per hour with 5 mg per hour and 15 mg per hour. So 15 mg per hour patients, for poor grade patients, it reduces the cerebral vasospasm. But the overall side effect profile for clazosentan is worrisome. Like it has a pulmonary complications and hypotension also. CONSCIOUS 2, even CONSCIOUS 2, they have looked for a 6-week primary composite endpoint and then 12-week endpoint. They have seen nothing difference between both the groups. And then in addition to that, lung complications, anemia, hypotension were more for clazosentan. But there is a subgroup analysis where clazosentan reduced vasospasm related morbidity in poor grade patients. CONSCIOUS 3, this is abandoned, and even till that time the result was in a disappointing way. Tyrolazad, it is an inhibitor of iron dependent lipid peroxidation, so it can helpful in reducing the vasospasm by reducing the lipid peroxidation, and it is licensed for usage in several countries. It reduces the mortality. So here is the picture where you can see the vasospasm. So all this nimodipine is very effective amongst all the other drugs. And then cilostazol. Cilostazol is a phosphodiesterase 3 inhibitor, and it helps in reducing the vasospasm because it increases the vasodilation. And even cilostazol has antiplatelet properties. So it reduces the microthrombosis. So cilostazol, it is having a positive profile for usage in cerebral vasospasm. So vasospasm management. So first identification and then ruling out all the other causes of delayed deterioration. And then CT at the same time to rule out all this. And then at the same time, all these accessory tests can be done to confirm the cerebral vasospasm. And then CT perfusion scan, it is a better alternative to the DSA. And then consider invasive hemodynamic monitoring for unstable patients who are having heart failure, myocardial ischemia, and then neurogenic pulmonary edema, Takotsubo-cardiomyopathy. All these are the complications of subarachnoid hemorrhage because of excessive catecholamine storm. So mainly we have to ensure, as I said before, all these are there. So normovolemia, maintaining a hemoglobin more than 9 grams per deciliter, maintaining in a good saturation, optimal ICP maintenance and monitoring, and with the proper positioning of EVD, inducing hypertension. A beginning, we have to increase a 20 millimeter mercury to the baseline, and then based on the patient response, we can titrate. So, and then they have mentioned one more thing. So norepinephrine, phenylephrine, dopamine, dobutamine. Among these four, which drugs are superior in maintaining the hypertension in SAH patients? So they are considering norepinephrine, phenylephrine are the first choices for maintaining the hypertension. And if you are seeing no response in maintaining blood pressure, then vasopressin can be tried along with this norepinephrine and phenylephrine. But they are suggesting not to use dopamine or dobutamine because dopamine is arrhythmogenic and dobutamine can cause a drop in blood pressure. Consider early balloon angioplasty. So we have to initially try with the induced hypertension, and if there is no response to that, early balloon angioplasty can be done. But prior to the balloon angioplasty, we have to rule out the infarct. So if you are suspecting any acute ischemic infarct, then early balloon angioplasty is not going to be helpful. Coming to the triple H therapy, initially all the previous times, hypervolemia, hypertension, hemodilution have been targeted, mainly to improve the cardiac output. The main problem with triple H therapy is cardiac failure, pulmonary edema, fluid overload, and overall complications are high. So as of now, there is no triple H therapy. Only induced hypertension has to be tried, that too in symptomatic vasospasm patients. But maintaining an extreme hypertension can have side effects like these patients can have increased edema and even stroke can happen. So this is what I have mentioned. SBP of about 200 can be maintained, and even if patient has ICP monitoring, CPP has to be targeted about 70. So I have mentioned all these are the, other than calcium channel blocker, nimodipine has all these properties like antiplatelet aggregation effect, and then it enhances the collateral circulation, and then it increases it favors the blood rheology. So viscosity will be reduced. Yeah, phosphodil, it is a Rho kinase inhibitor. Rho kinase is a calcium independent vasospasm. It plays a major role. So for irreversible vasoconstriction, phosphodil can be tried, and there are some favorable outcomes promoting the phosphodil. Erythropoietin can be tried, but the exact mechanism of neuroprotection is poorly understood. But basically, erythropoietin is believed to, it inhibits the apoptosis, it reduces the oxidative damage. Sildenafil, there are few trials which has promoted sildenafil that can be tried because it causes vasodilation. Endovascular reversal. So if patient is not responding to the induced hypertension, then angioplasty has to be done. The mechanical angioplasty preferably has to be done within 2 hours of the symptom onset. So the efficacy of this mechanical balloon angioplasty is nearly 100%. And the vessel rupture chances are around 1%. So for vasospasm, which are, so any procedure or any intervention, endovascular intervention, they are helpful for proximal aneurysms. What about the distal aneurysms, where we cannot approach to that point? So in these patients, there is a literature favoring milrinone. Milrinone can be tried intravenously or intravenously, or even intracisternal milrinone administration. But the problem with milrinone is it is an inodilator. So there can be a drop in blood pressure in these patients. So all the other intraarterial vasodilators, papaverine, nifedipine, verapamil, nimodipine has been tried, but the results were inconsistent. So intravenous milrinone. Milrinone is a phosphodiesterase 3 inhibitor. It can be administered either to the subarachnoid system intravenously or intraarterially. There is a protocol called Montreal Neurological Hospital Protocol. So some countries, they are following this protocol for administration of milrinone in resistant cerebral vasospasm, where induced hypertension is targeted and failure. So initially, identification of the cerebral vasospasm, ruling out all the other causes, immediately giving enough fluid bolus. Following that, milrinone giving with a bolus of 100 mics per kg, followed by 0.75 mics per kg per minute. To maintain the blood pressure, norepinephrine, phenylephrine can be used to maintain the MAP. And we have to maintain for a half an hour. And we have to assess the patient. If you are seeing any clinical improvement, then you can continue the same dosage of infusion, like 0.75 mics per kg per minute. And if there is no improvement, then this dose can be doubled, like 1.25 mics per kg per minute can be tried. So this is the protocol. But there is no recommendation of milrinone as of now by ASA. Medically refractory vasospasm, even sodium nitroprusside, which is a nitric oxide donor. The main pathophysiology in vasospasm is depletion of nitric oxide because of endothelin overproduction. So nitric oxide donors has been tried locally into the lateral ventricles. In these patients, the results were inconsistent. Along with this, even cervical sympathetic blockade with regional anesthesia can be tried. So all these things I have mentioned already. Yeah, thank you. Sir?
Yeah. Thank you, Dr. Anil. Bibu Kalyani, ma'am.
Thank you, Anil, and your excellent presentation.
Thank you, ma'am.
I don't have anything to add on that because he has covered everything. So there is, I think, one question is there. Can I see that in the chat box?
Yeah, ma'am. Dr. Anil, there's a question for you.
I'll read that, sir. What does ASA or neurocritical care guidelines says about the level of induced hypertension? Would you target systolic blood pressure of 200 plus for all patients with vasospasm, irrespective whether aneurysm is secured or not? Is patient with ischemic heart disease or recent stroke? Sir, as far as I know, this induced hypertension is after the clipping of aneurysm, sir.
Yeah, fine. Yeah, Dr. Anil, you can continue.
Yeah, sir. So other than that, I think there is a recommendation as per ASA guidelines, induced hypertension can be tried. Based on the patient response, it has to be titrated. So, and we should not waste time by giving induced hypertension and waiting it to act on the patient. So the presentation I have mentioned earlier, so we have to wait for just 2 to 3 hours. If you are not seeing any improvement in the clinical response in the patient, then immediately we have to plan prophylactic balloon angioplasty.
Yes, done that. And another.
And then coming to the ischemic heart disease, it is not advised as it can increase the myocardial oxygen demand and all. So based on the patient tolerance, the BP augmentation can be titrated.
And also from the baseline, you can titrate up to 20 and 30, gradually titration of the BP. And it differs from patient to patient. That is said that what is the condition of the patient, the cardiac condition of the patient, so all these things.
Yeah.
Any other questions? So I think any question from our senior colleagues who are attending, I don't know. But he has very nicely, he has said about the pathogenesis and how to diagnose and clinically, and also by the our investigation methods and what are the disadvantages of each method. He has already said that. So there is nothing I should add to that. And Zulfikar, if you want to add something.
Ma'am, I don't have to add anything. Anil has covered the whole topic nicely.
Very
But
nice.
for the benefit of our students, I would just request Anil, just if he can summarize as what would be a practical management that we can, for a practical approach to the prevention and treatment of vasospasm. What are the common things that all of us
In
need to
practice.
keep in mind? Anil, can you just summarize for the benefit? You have covered all of
Yes.
that, but can you just summarize the things in view of how much fluids we need to give? What
Yes.
is cerebral perfusion pressure? What about the EVD management, hypertension targets, PCD?
Yes, sir. So it is based on the initial presentation of the patient, sir. So if patient has a toxic look, or if patient presented with LOC, or patient needing mechanical ventilatory support, and the CT showing a thick SAH with IVH, so all these can make us to think that there is a high chances of vasospasm in these patients. So in these patients, we have to strictly assess the patient on daily basis if we have a TCD, because the patient is usually drowsy. So you cannot make out a new clinical findings in these patients, even if you examine daily. So for these patients, there should be an additional help like TCD, or even a CT can be repeated. That is what literature has said. Even there is no wrong in repeating a CT if you have a suspicion. So the early identification of vasospasm is the main thing in management. So early identification and then confirmation. So ruling out all the other possible causes and coming to a conclusion. And then ASAP, we have to induce hypertension with norepinephrine or phenylephrine based on the patient tolerance. We have to target a systolic blood pressure up to 200, or MAP up to 140 can be tried. Along with this, if patient has EVD, even CPP, ICP monitoring can be done. We can target a CPP of above 70 can be tried. Along with this, euvolemia has to be maintained. There should not be absolutely no hypovolemia, and intake output charts. Usually, it's better to maintain a positive balance, milder positive balance in these patients. And then early identification of hyponatremia, and then identifying the reason for hyponatremia is important in these cases, sir. So even it can be SADH, because even SADH can present in SAH patients. So in treating the SADH is different from an usual patient who has an SADH. So the option for treatment is not fluid restriction, but sodium replacement with 3% saline. Along with this, targeting euglycemia, so 140 to 180 sugars, and along with that, maintaining a HB of about 9 gram per deciliter, preventing anemia, and in order to that, we have to prevent the fever, because chances of getting infection because of EBD is very high. So we have to take utmost sterile precautions in preventing any chances of infection, sepsis. These patients can be on mechanical ventilator also. So ventilator associated pneumonias and all, it has to be, we have to be very vigilant in identifying all this. Along with this, we have to prevent the temperature rise in all the time. Along with this, uh, after inducing the hypertension, we should not wait for more than 2 to 3 hours. If we have a facility, then we have to immediately talk to the interventional radiologist, and then we can plan for prophylactic balloon angioplasty.
One question
Yeah,
for
anything
this.
to be added, ma'am?
Anything regarding the anemia in
Yeah,
patients who are with brain intact brain, and there is no change in they are not diseased. So in
yeah.
that case, we can take up to 6 grams of hemoglobin. So
Okay.
why in subarachnoid hemorrhage, why you need to have more than 9? what happens, what occurs, and why the anemia occurs there?
Yeah, ma'am. The oxygen carrying capacity will be reduced, ma'am. So the perfusion and all, even though we are maintaining adequate perfusion pressure, but the oxygen carrying capacity plays a role in reducing the vasospasm, ma'am.
It is also the blood-brain barrier. It is
Yeah, ma'am.
disrupted, no? So that is why this is leaking, and that causes your. And it has been seen that the brain oxygen tension PbI2 is also reduced in cases of anemia in subarachnoid hemorrhage. So and vasospasm occurs more, and that time that CSF oxygen, this brain cell oxygen PbI2 is reduced, so that is neuronal injury, and that is why it is very important. And they have seen that when there is more than 11 grams per cent, the outcome is always good, and so that is one thing. Another thing, that the mechanism of what occurs in cases of this nimodipine again, and one thing you have said that in cases of fluid,
Yeah.
they have fluid, and you read that you have to sometimes you give albumin. Where do you have albumin?
Yeah, ma'am. Ma'am, yeah, ma'am. Albumin for BP augmentation, there is a trial, ma'am. ALISA. So SAH, ma'am. So in that trial, they are seeing a positive outcome because of maintaining, because of using albumin for BP augmentation and maintaining a euvolemia along with that. They have found a positive effect in these patients, ma'am. Even albumin has some immunomodulatory.
Modulatory action, yes.
Yeah, ma'am. So
Anything else?
Dr. Anil, any comments on the use of phenytoin? Phenytoin is one of the common
yeah,
drugs.
sir. Yeah, sir. Sir, ASA recommendation is do not use any anti-epileptic drugs unless there is a documented seizure, sir.
Seizure, yes.
Yeah. So it's better to avoid
Yes.
anti-epileptics.
Yes, sir.
Because again, they interfere with the cognition, and we may miss subtle
Yeah, sir.
cerebral vasospasm.
Yeah, sir. Patient can be drowsy, no, sir, with
Yeah.
yeah.
That is one of the things that we need to keep in mind.
Yes, sir.
Are you using this nimodipine? All are using millinone. How you are using the infusion of millinone in your center?
Pardon, ma'am?
Millinone infusion.
Ma'am, we are using milrinone infusion at our center. We do not use it frequently, but we do use it many a times.
We also use it. So that's very good. And they have already mentioned about the nimodipine because of it has some collateral
Leptomeningeal collateral circulation. It can enhance.
leptomeningeal
Yeah, ma'am.
collateral cell.
Yes.
Advantage of that.
Dr. Anil, any can you just summarize the hemodynamic targets in terms of CVP, hemoglobin, as you are already oxygen saturation, because this is one of the things that we commonly follow in ICU. Once we have a patient with cerebral vasospasm, what should be the CVP that we should target for pulmonary capillary wedge pressure if we have
Sir,
a catheter in situ?
because the literature is saying pulmonary catheters, pulmonary arterial catheters, better to opt for a central line just for the hemodynamic maintenance. But by using pulmonary artery catheters, there is no extra benefit.
Yeah. So what should be the target CVP if we have a CVP in situ, though we are now shifting to IVC diameters?
Sir, IVC diameter, we can see if the patient is on mechanical ventilator, then we can see the distensibility index, sir. Based on that,
Fine.
we can see whether patient is fluid responsive or not, sir. So, and then coming to CVP, I think around 8 can be fine, sir.
8 to 10, and hemoglobin as 9 to 11.
About 9 grams, yeah, sir.
Oxygen saturation a little bit supranormal oxygen saturation greater than 95%.
Yeah, sir. Above 95% is can be
Yeah,
helpful.
greater than 95%. And
Yes.
cerebral perfusion pressure, as you were already saying, greater than 70.
70, sir. Mean arterial pressure above means around 140, sir. Systolic blood pressure 200 to 220, sir.
And also one thing we need to remember that we need not to make any attempts to control mild or moderate hypertension.
Yes.
If a patient is having hypertension, mild or moderate, we take it as desirable. So we should just try to institute anti-hypertensives if the blood pressure goes beyond 170 or beyond 180 millimeters of systolic.
Sir, I have a doubt, sir. If these patients are on EVD, prophylactic antibiotics, sir.
Prophylactic antibiotics with EVD, we do not have any guidelines that
Yes.
They are helpful. So if we
It
are
is
having
kept
an
about
EVD,
5 days, I think we can use medicine.
yeah, it's better to remove it within 3 to 5 days. So we do not have, as of now, we do not have any guidelines that if we institute prophylactic antibiotics with EVD in situ, it will decrease the chances of ventriculitis or meningitis.
Okay, sir. Sir, there is a question, sir, from Shruti Gupta. Should we give tablet nimodipine if BP is approximately 120 mm mercury?
Yeah, should we give?
So it can be given in half dose. Like I said before, 30 mg secondarily can be tried in this patient.
30 and 30, yes.
Because there won't be any much hemodynamic difference with 30 mg of nimodipine.
They have also done, there are studies on 30 and 30. There are also studies, every 2 hourly, you give 30 milligram orally when you think that patient is having hypertension.
Any other questions from any students?
What about magnesium?
Ma'am, magnesium, hypomagnesemia has to be corrected, ma'am.
Corrected, yes.
By giving extra magnesium, there is no change in the final outcome, ma'am. That is what I think MASH 1 trial, they have supported giving magnesium sulfate, but the study was, I think there is some problem. It was a faulty study, ma'am. This is what I remember, ma'am.
MASH once supported the use of magnesium, but once we did MASH 2, there was no beneficial effects of magnesium. So the current consensus is that if we have hypomagnesemia, it needs to be corrected.
Yes, sir.
It's better to do a serum magnesium in the preoperative period. So if we suspect a hypomagnesemia, it would be better to correct it in the preoperative period or in the intraoperative period once the patient is being anesthetized.
Okay, sir. Sir, there is a question, sir. Is there any role of intravenous nimodipine? I think it's intraventricular nimodipine, I guess, sir.
No, Dr. Zoya is asking about the intravenous nimodipine. Intravenous nimodipine, we use intravenous nimodipine, but there have been trials between a comparison has been made between intravenous and oral nimodipine.
Okay,
and it has been found that oral nimodipine is better because there's an increased incidence of hypotension with intravenous nimodipine.
Okay.
That is what the trial says, but there are many patients, particularly WFNS grade 4 patients who have a decreased gut motility, or they may be on inotropes because of severe hypotension, where the oral nimodipine may not be really, there may be a poor absorption of oral nimodipine. So IV nimodipine definitely has a role in such scenario. Otherwise, it has been found that if we compare the IV nimodipine with oral nimodipine, there is an increased incidence of hypotension with intravenous nimodipine.
So what is the dose of intra-arterial nimodipine, sir?
Intra-arterial nimodipine, it is 3 milligrams in each vascular territory.
Okay,
if we are going for one major arterial territory, so it's around 1 to 3 milligrams.
Okay, sir.
What are the doses of other intra-arterial medicines? Well, I have to go through the table. I do not really remember the doses of all medicines.
Yes,
Dr. Anil just gave us some idea about the Montreal protocol.
sir, Montreal protocol 0.075 mics per kg per minute has to be given as an infusion, sir. So we have to wait for half an hour for patient improvement. And if you are seeing no improvement, the dose has to be double, sir. So 1.25 mics per kg per minute can be given, sir. And then I have read about milrinone doses, sir. Not milrinone, the other one, sir. Intraventricular milrinone, intracisternal. I forgot about that, sir.
I will just post a link for the benefit of everybody. There is a very nice article, a review article. So
Yes,
the
sir.
doses and all that, everything is in this article. This is a recent article published in 2016 and 17. So all the students, they can go through this article and they will get to know the doses, the recent developments, and the main things that we need to know about the management of cerebral vasospasm.
Yes, sir.
Also, can I mention one article?
Sure, ma'am.
By Chandranil Chug and Himanshu Agarwal. It is this is it published into 2020. So this article, I'll send it.
And you can just post it in the chat box.
Yes. I don't know how to post it in the chat box.
Ma'am, just you can copy the URL of the article if you open it in any of the web windows, and then you can put CTRLV in the chat box. Or if you can just forward it on the WhatsApp to me, I will just put it in the chat box on your web.
Chat box.
Ma'am, chat box is at the bottom. Once you take the cursor to the bottom of the screen, in more, it will come chat.
Chat box. The desktop. This is the Chug article. This. Posted, yes.
Ma'am, yeah, it has come.
It has come.
Yeah.
I have our manager here. He helped me. So I must thank Dr. Anil for that excellent presentation.
Thank you so much.
And also the inputs from Dr. Julfikar.
Thank you, ma'am.
Sir has given more than 1 month time to prepare this one. Sir has given 2 months for preparing this presentation.
Dr. Anil, thank you. You have worked really very hard. You have covered the topic extensively.
Thank you, sir.
Sir has already mentioned me that he is very excellent speaker, and he will be very good. So I have already witnessed that now. Very nice.
Thank you, ma'am.
Ma'am,
One
sure.
student was there.
Yeah.
There was she. Where is she? She hasn't asked anything.
Yes, ma'am. I have heard it's like sir has also given good input, and Anil sir has also said
Everything
it's
is
very
very
nice.
clear to you, no?
Yes, ma'am. It's clear, and like it will help us out in our final exams.
The advantages of milrinone, he has already said, and it is the delayed cerebral ischemia is less with milrinone, and also you can avoid intervention. That's what they have said. Isn't that, Dr. Anil?
Ma'am?
Milrinone, the advantage is delayed cerebral ischemia is less with milrinone. In that.
Yeah, ma'am. Yeah, ma'am.
And also you can avoid interventions.
Yeah, ma'am. Because of its antiplatelet properties, it reduces the microthrombosis also, ma'am, along with vasodilation.
So thank you, Julfikar.
Thank you, ma'am.
So now we can close the session, no?
Okay, ma'am. Okay, ma'am. Thank you. We'll close the class. We'll close the session.
Thank you, ma'am. Thank you all.
Thank you, Dr. Anil. Thank you, ma'am. Thank you.
Yes, sir. Bye, sir.
Bye.